All right, so we still have some people joining us, but we are going to get started. Hi, everyone. Thank you for joining us, and welcome to the 7th Annual Gillings X. My name is Kay Schaefer, and I'm a second-year MPH student in the Maternal and Child Health Department and the chair of the Student Global Health Committee. As some of you may know, we usually host Gillings X in person, but because of the current circumstances around COVID-19, we have done what we in public health do best, which is adapt to constantly changing environment and have gone virtual for the first time. The theme for this year's Gillings X is breaking down barriers. How can different sectors collaborate to achieve better health outcomes and increase equitable access in a rapidly globalizing world? Our three amazing speakers will share with you what breaking down barriers means to them and how they have done so through their global health work, which is needed now more than ever. Each speaker will give a 10-minute talk on their work, and we will have time for a short Q&A session after each talk. Please feel free to write your answers into the chat or the Q&A session throughout their talks, and I will ask them at the end. This webinar is being recorded, and we ask that you please keep your video turned off. Before we begin, I want to give a huge thank you to all of Student Global Health Committee for making this event possible, to Dean Reimer for her continuous support of Gillings X and SGHC, to our wonderful advisor, Naya Villarreal, and to the Gillings AV department for helping us how to host a webinar. All right, so let's get started. Our first speaker is Sheila Drakely, and her talk, How Virtual Patient Advocate Has the Potential to Shape Access to Women's Health in Australia and the World. Sheila is a second-year MPH at UNC student in the leadership concentration. Passionate about combining technology with health, she had the pleasure of working on a web-based virtual patient advocate project focused on providing preconception care and advice. Sheila helped lead the pilot study of this VPA in Melbourne, Australia, to understand what women look for when searching for health information online, where the current gaps lie, and how a VPA could be a viable solution.
Hi all, hopefully you can hear me. All right, I'm gonna get started. I never thought I would find myself working in women's health, nonetheless preconception health. Ironic considering I myself am a woman who has always had access to suitable healthcare. But as I traveled the world, our own country, and looked in my backyard, I saw how many women, young and old, lacked that right. So I found myself early last year leaving Boston, Massachusetts and traveling to Melbourne, Australia to work alongside a diverse team of doctors, nurses, dietitians, and researchers to address this global issue. So for those of you who don't know, Australia isn't really close. 35 hours of travel to be exact. So why Australia? Well, Australia and the United States are similar, but they have many differences as well. Both countries have slightly larger percentage of females compared to males. Both have a growing number of minority populations and a similar percentage when it comes to their population who reside within rural regions of that country. While Australia has a universal healthcare system and the United States does not, Australia still faces many issues regarding partner violence, contraception, and safe practice of sex, maternal health, poor access to rural regions of the country, with the United States suffers from as well. Now, before I go into this topic, I want you to meet one of my colleagues who I think is incredibly knowledgeable, very compassionate, and might just be the future of women's health.
Hi, I am Gabrielle, but you can call me Gabby. I am a nurse created by a research team of health professionals and computer scientists from Boston Medical Center and Northeastern University. My goal is to help you become as healthy as you can be, because by investing in your health, you are investing in yourself. I also really want to help women who want to get pregnant at some point become healthier. Everything you will learn with me can help you become healthier right now and in the future. Does that sound good, Emily? Before we get started, Emily, I want to talk to you about why health is so important to me.
As you can see, Gabby is a virtual patient advocate, which is a computer-generated character, often a healthcare professional, who simulates face-to-face conversation with patients to communicate key health messages. She was designed by a team in Boston, Massachusetts, for African American women to understand preconception health and preconception healthcare issues that this population faces. Gabby's name was modeled after a well-known African American figure to represent the representation of this study in Boston, Massachusetts. Gabby was found to be effective in decreasing preconception health risks for African American women in the United States, but she has never been tested for her acceptance to women of other ethnicities or women living in other countries. So why virtual patient advocates? VPAs have been proven effective in overcoming barriers of healthcare, including reaching a large number of patients, alleviating clinic time and human resource constraints, controlling costs, and having high patient acceptability. Due to its online delivery, it enables access to healthcare at a time and location that is convenient for a patient. Our team wanted to test this idea out and see how VPAs could be beneficial to a diverse group of women. Since Gabby had never been tested for this acceptability with women of different ethnicities and women living in other countries, this is exactly what we wanted to determine in this study. We looked at women who had different ethnicities in different countries and said, what do you think of Gabby? As you can tell, Gabby is currently a little bit outdated. So we also wanted to know what technology and design changes could we make to make Gabby more applicable, specifically in the Australian context. So what did we do? We conducted 7 focus groups with 31 women, ranges between the age of 18 and 45, both residing from either metropolitan or regional Victoria. All participants were recruited via social media advertising. With women representing 4 different continents, multiple native languages, and 4 ethnicities, these women were put into focus groups and allowed to interact and react to Gabby. We asked them questions like, what was your first impression of Gabby? Did you like her? Was there anything you disliked? Is there anything that you learned during your short time with Gabby that you would consider applying to your real life currently? What changes do you think need to be made to Gabby? Is there anything that we could change to make her more acceptable to women living in Australia? And would you interact with Gabby if you were given that chance again? These responses, as well as others, were recorded and transcribed in a qualitative analysis and coded for themes and sub-themes. We collected these responses and found that there were 4 major themes and 7 sub-themes. I'd like to highlight a few of the 4 major theme findings that we found. The first theme is regard to an individual's perception of VPAs for preconception care and information. We wanted to see what people felt when they followed up with topics such as health-related issues to women's health. Patients felt that Gabby was personable, they were able to interact with her, and she asked them topics that were important to them, similar as if you were interacting with a healthcare provider. Some participants even noted that they felt the information Gabby shared was trustworthy. For example, participant 24 from Metropolitan Victoria said, quote, I think I would be more inclined to use Gabby than say, just Google. When you Google, you may not be sure where this information is coming from. I could see what Gabby could provide for me, and she could become my first resource of information. The second theme revolved around patient satisfaction with Gabby, including her appearance, speech, navigation, and how they connected with her during this activity. Participants did not find her appearance to impact their ability to interact with Gabby, nor her North American accent. Participants felt that the information Gabby portrayed was relevant and that they would be able to build that trust with her over time. Participant 13 from Metropolitan Victoria said, "She looks like she cared about me, even though she was an animated person. She seemed really nice and friendly, and I felt comfortable using this system." However, the lack of navigation features, as well as the outdated technology, was the biggest drawback participants mentioned in regards to their interaction with Gabby. The third theme had to do with a wish list that we asked participants to create to see what modifications or changes, additions or subtractions that they would like to see in Gabby for future iterations. These modifications included technological advancements, enhancements to the navigation system, as well as incentives to have them interact with Gabby, and the addition of missing information. The biggest drawback the participants felt currently about the Gabby system is that she is only web-based. The fourth theme revolved around Gabby and her real-world application, such as described by the way Gabby could interact and aid our current healthcare system. This ranged from how Gabby could be interacting with an individual prior to seeing a provider, as well as providing preventative care resources and information for a participant to use in their free time. Based on our team's findings, we found that VPAs do have the potential to increase women's access to preconception healthcare and information. The Gabby system was accepted by women in Australia, and they did identify a range of modifications that they would like to see to increase the relevance and the appeal to using this technology, as well as to increase the ease of access and address certain navigational issues around the system. Context-specific advice, relevant and trustworthy information were considered most important to the women from our study in Australia. Gabby, along with other virtual patient advocates, have a great global potential to reach patients in areas where there is low access to healthcare, to convey content-specific and factual advice to individuals interacting with these VPAs, have the ability to provide real-time information when there's clinic restraints or a lack of resources in the healthcare system, as well as to provide an alternative way for patients to receive health information when it is not necessary to have a face-to-face interaction with a healthcare provider. Ultimately, Gabby and other virtual patient advocates could help educate individuals that health is a lifelong journey. I would like to send a special thanks to my team who I got to work with in Australia, the MICRI and the Monash University team, especially Dr. Jackie Boyle and Dr. Ruth Walker, as well as the following contributions listed on this slide, for helping me with this project and seeing this through. Thank you.
Great, thank you so much, Sheila. So I want to remind everyone that our Q&A and our chat box is open, and I'm going to get us started off with one question for Sheila. Sheila, how do you think VPAs can be utilized during the COVID-19 response?
So I think that's a great question, specifically in a time where we have to social distance, and being able to go into your provider to ask questions that aren't related to the current COVID-19 epidemic might not be the most appropriate thing to do to put yourself at risk. So a VPA is a form of telehealth or telemedicine, which, as you can see from the short 45-second clip, Gabby has the ability with the technology we have in 2020 to be able to provide information. And if you could see, individuals could also click on responses and interact with her. And I think specifically now in this time, it is a great way to be able to provide information in an alternative way versus just reading off, say, an article or a piece of website information that you find while Googling.
Great, thank you so much. So we have a few questions from our attendees. The first is, do you see Gabby being adapted to other medical specialties?
Yeah, that is a great question. So actually right now, there are other forms of virtual patient advocates out there that have been used in different disciplines of medicine, not to the degree that Gabby is currently being used. But Gabby actually does also have a male counterpartner who acts as a similar provider of information for men regarding reproductive and sexual health. Additionally, also providing information around women's health, since it's important to understand, no matter where you are going in life, that you should be able to respect the opposite sex and any sort of their health information.
Great, thank you. Another question we have is anyone using Gabby at this time?
So currently, Gabby, as I mentioned, was developed by a team in Boston, Massachusetts, and she's going through some of the iterations that we had suggested that we found during our time studying her in these focus groups. Unfortunately, she's not currently globally or wide range available to individuals, though we did get a response that most people wish that she was. I see this being something coming sooner rather than later, where individuals will actually be able to use her. But since she's still also going through some testing and studies within the United States, she's currently not widely available unless you're participating in one of these studies.
Great, thank you. And we have some more questions, but to keep us moving, we only have time for about one more. And that is, once Gabby does become accessible to a wider audience, do you think that there's a chance she will be available free of cost to anyone, especially for folks who might be in lower income areas?
So the study done in Boston worked specifically with individuals who were from lower socioeconomic status within the Boston area. So the idea would be to hopefully use her mostly in that context. When it comes to where she's going to kind of be available, the idea is to have her available to all who would like to, but kind of the details around that haven't been decided entirely yet.
Great, thank you so much, Sheila. All right, so we are going to move on to our second speaker. Our second speaker is Ben Kaplan. His talk, I Know Me, Complex Care Patients and the Power of Photo Voice. Ben is a fourth-year medical student and current MPH candidate from New York City. He will be applying to family medicine residency programs next year and plans on splitting his career between community-based primary care, health equity research, and medical education. He is passionate about increasing access to primary care, particularly with individuals living with chronic illness.
I hope I'm audible. It would be awkward if I were not and then went through the whole thing. But there's a risk of that, and it's a risk that I'm willing to take.
We can hear you, Ben. So
okay, perfect. Okay, so thank you, Kay, for that wonderful introduction and for organizing this entire conference and working with the team to adapt it to our exciting new digital landscape. So I'm going to share my screen now. And I think it should be working. Is it shared?
Yes, we can see it.
Okay, perfect. And now I will do this. Okay. So like Kay said, the title of my my talk is I Know Me, Using Photo Voice to Foster Dialogue with Complex Care Patients. So I'm going to start with a photograph, and I want y'all to just look at this photo, take a couple of seconds, and just think about how it makes you feel and what the person who took this photo might have been thinking when they took it. So I'm going to tell you a little bit about the person who took that photograph, sort of in the style of a medical presentation that you would receive if you were rounding in the hospital or in a clinic. So Mr. G is a 63-year-old African-American male. He has a past medical history of poorly controlled hypertension complicated by a stroke. He has end-stage renal disease managed on dialysis and chronic low back pain. For his social history, he is a former smoker and he lives alone in Chapel Hill. He's insured on Medicaid, and he has had 3 ED visits, that's emergency department visits, and 2 hospitalizations this year. So zooming out a bit, in 2015, it was revealed that the most expensive 5% of Medicaid-only enrollees account for almost half of the expenditures for all Medicaid-only enrollees. And Mr. G is one of this 5% of particularly expensive patients. And these patients are known by a number of different names. They're called superutilizers or hotspotters or frequent flyers, or as I like to call them, complex care patients. And specific definitions of this population, to the extent that it even is a population, vary from institution to institution, even within institutions, but they all encompass a certain degree of medical and social complexity. So the definition that I have landed on that I really like is that a complex care patient is a person whose combination of chronic illness and structural vulnerability results in a cycle of fragmented care. So these are people who largely are unable to attend outpatient clinic visits on a regular basis. They don't really have a consistent primary care doctor a lot of the time who they can follow with. And in attempting to manage their chronic illnesses by themselves, these illnesses are suboptimally controlled. So they wind up coming to the emergency room and often being hospitalized for often preventable complications of their chronic illnesses. So a question that I'm always finding myself answering is, are complex care patients non-compliant? Are these patients who are not doing their fair share of the lifting in the clinical contract? I think the answer is, generally speaking, a resounding no. And in looking at the research that we have on this population, we really need to be asking ourselves, what is the difference between a study and a dialogue? Who is in control of the conversations that we are having about these patients? And I say about intentionally, because from my view, a lot of these people are not in the room when we are talking about them. And on that note, I think it's really important to take a health equity lens to all of this and to maintain an awareness of structural and historical context, particularly here in North Carolina, where we're working in the context of structural racism, historical abuses of communities of color by researchers. For example, the Tuskegee syphilis trial, the case of Henrietta Lacks, where her cells were harvested without her consent and used for research, as well as the general concept of medical apartheid as discussed by Harriet Washington in her book of the same name, which I highly recommend. Get back here. Okay. So my question is, what does it look like to live as a complex care patient? How do chronic illness and socioeconomic barriers interact to shape a person's experience within the healthcare system? So I have organized a research study to answer this question. And I've recruited participants from a number of specialized complex care management programs at UNC and the Departments of Internal and Family Medicine. My goal is to recruit 30 people. I've recruited 12 so far. And my method is photo voice. And a lot of y'all have probably heard of photo voice before, but it is a method that was invented by Wang and Burris in 1997, based on a Brazilian philosopher, Paulo Freire's theory of critical consciousness. And the method is to provide research participants with cameras and ask them to document their experiences in response to a research question. And the question that I ask participants in this study is, what makes it easier or harder for you to be healthy? So each study participant receives a digital camera to borrow and take home with them, and they spend 1 to 2 weeks taking photographs in response to that question. And then we get back together for a second one-on-one meeting, and I just ask them to explain their choice of photographs to me. And I don't ask any questions throughout the interview. It's a totally unstructured interview. The only guidance that I provide them is this framework of questions called SHOWED. And it stands for, what do you see here? What's happening in this photo? Does this happen in our or your community? Why does this happen? And what can we do about it? and I audio record and transcribe that interview for qualitative analysis alongside the photographs. So now I just wanted to show you a couple of the photographs that have come out of this study. So just like I asked you with the first photo, take a second, look at this photo, and just think about how it makes you feel. And to the best of your ability, try to imagine what the person who took this photo was thinking when they took it. Okay, so here is what the photographer actually had to say. I got to dialysis through weight loss surgery. During the surgery, my blood pressure dropped and my kidneys failed. Dialysis took my life from me. I felt like I had been thrown out in society, that I had no other choice. Before, I only dealt with me and with a selective group of people that were in my circle. Now I have to deal with a whole bunch of people. It's been one sickness after the other, one hospitalization after the other. So I don't think I need to say much more than what this person has been able to say about their own experience, but I really want to emphasize how different this story can be from the story that we necessarily assume when we see somebody who is on dialysis. So now returning to the first photo that I showed you by Mr. G. I've already asked you to kind of reflect on this photo, so I'll just show you what he had to say about it. This is the day that I went to get the MRI for my back. I felt like I was in prison because of all those lockers and the locks. I found out that day that I had a ruptured disc but no need for surgery. They're going to send me to pain management, and I'll tell you now, I'm not going to take any pain meds because I'm an addict recovering since '93, and I know me. So where do we go from here? I've enrolled 12 participants to the study, like I said, and my goal is to enroll 30. At the end of the study, I'm going to hold a focus group for all participants to come and speak with each other and see each other's photographs and kind of have a gallery walk and identify common themes between their work as a collective whole. I'm going to conduct constant comparative analysis using the photographs and the interview transcripts and identify major themes in the hopes of influencing future clinical interventions to help engage this population better. And I'm also hoping to organize an exhibit of photographs and captions at UNC to really start a conversation between these patients directly, as they will be invited to participate in the exhibit, and folks like us, people in the healthcare world, people in the public health world, who are really going to have a hand in shaping the policies and the clinical interactions that so deeply affect these people. And I just want to conclude with a brief discussion of the global implications of this project, because you might notice I am the person in this group who has a local project right here in North Carolina. So I think with all of our research, whether it's here or whether it's across the globe, it's really important to pay attention to this difference between a study and a dialogue, and to ask ourselves who is in control in each one of those setups. And in our effort to amplify marginalized voices and bring people to the table so that they can advocate for themselves, we need to ask ourselves whose story is being told when we are sharing these stories. Are we sharing our own story of interacting with this person, of interacting with this narrative, or are we really letting them tell their own story? And I think that is as important domestically as it is internationally. I think just generally speaking, the concept of cultural humility, of experiential humility is crucial. We need to respect people's expertise over their own lives. And that goes for public health professionals, that goes for medical professionals, anyone who we interact with. We have to understand and embody the knowledge that we don't know them better than they know them. And always ask, what do I know and what do I not know? So I'll just close with a quote that I really like. My mentor uses this quote a lot. If you're not at the table, you're on the menu. It is absolutely crucial now more than ever that we bring to the table the people who we are talking about. Because when we try to make decisions about people's health, whether that's from a clinical standpoint or a public health standpoint, when we try to make decisions about somebody without them in the room, we create a vacuum where dangerous assumptions can take the place of truth. And that can result in the perpetuation of violence, of mistreatment, even if we mean well. unless we are directly interacting with the people we are seeking to help, we're not helping much at all. So here are some resources for conversation that I would be happy to send out later. And I have lots of acknowledgements. I work with the Center for Health Equity Research. They are a wonderful collection of researchers and clinicians and public health folks. So thank you so much to them for funding me and for supporting me this whole time. And thank you so much to the Gillings X crew for organizing such a wonderful event. I'm so jazzed to be here and really, really appreciate you all for coming to this digital event. So here are my references, and I would be happy to take questions.
Awesome. Thank you so much, Ben, for your talk. So I'm going to give folks a second to type their questions into the chat or the Q&A box and get us started with a question. How do you think lessons learned from photo voice exercises can be integrated into routine medical care?
I love that question. Thank you. So that's a question I get a lot about photo voice, and it's a question I'm always asking about photo voice. There's been some really cool research being done about actually implementing photo voice, or photo elicitation is what it's called when it's in the clinical setting, to like establish goals with patients. Primary care physicians can, or any primary care taker can use photo voice to start a conversation with a patient. You know, just go home, take some pictures on your iPhone, or take some pictures with a disposable camera even, and bring them in and let's talk about it. Because there is, this hasn't really been nailed down in theory yet, but I'm really hoping that there can be more discussion in the literature of how the process of taking a photo and showing it to somebody generates conversation that is not accessible through simply talking to someone. And I would love to see this be applied clinically, even if it's just in the mindset that we don't know everything about our patients and that we need to exercise humility when we're trying to learn more about a person's life. So yeah, thank you for that question.
Great, thank you. So a question from one of our audience members is, how is your research received by your medical colleagues, and are they receptive to photo voice as a methodology?
Another great question. So I'll be honest, one of the reasons I chose to come to UNC as for medical school is that we have this amazing department of social medicine, and social medicine department here is incredibly receptive to photo voice. They've been really supportive. I find that even if I'm talking to someone who doesn't really have a social medicine mindset or a public health mindset, there might be a little resistance at the beginning. But as soon as I show them a photograph and read them what the person who took the photograph has to say, that moment of, wow, I really did not assume that. I really did not see that coming. That moment of surprise or irony is worth its weight in gold. And after you have one of those moments, it's really hard to refute the need to be looking for more creative ways to empower people to tell their stories. So this is for, research. This is for advocacy. I think that this is just as applicable to the world of journalism. I also think I have a pretty self-selecting circle of like people who like this kind of stuff. But so do all of us. We're in a public health program. So we chose well.
Great, thank you. So another question from our audience is, I have noticed while working at UNC and in my own community engagement work that our area has a fairly fragmented health system. People go to Duke, UNC, Cone Health, etc. And if they are not highly health literate, they may not be able to give a good health history to a new doctor. Have your study participants spoken about this at all?
Yes. So I've done 3 separate photo voice projects, 1 here and 2 in New York City in East Harlem. And that is a theme that comes up over and over and over again. And I'm really hoping that I'm able to capture that with this project and convey it effectively, because that fragmentation is the perfect word. There is there's so much onus placed on individual people to advocate for themselves in our healthcare system. And that means that we're not doing a good enough job of advocating for the people we're trying to take care of. And a lot of that is because, as you say, we're working with a system that is deeply fragmented. And I think you see it right now with the response to COVID, unfortunately. Part of what makes this also difficult is that no one has the right information because there's so little centralized communication surrounding the measures that need to be taken to keep people safe. And I think that there's so many ways in which our work as public health professionals can be informed by the need to centralize and improve communication between clinicians and clinical staff and patients and their families. Yeah, it was a great question. Wow. These are great questions.
Yeah, they really are great questions. All right, we have time for one more, which is, I think that a transition to value-based payment models such as accountable care organizations has been very helpful in helping complex care patients and addressing fragmented care. However, the health equity piece still seems to be missing. Any insight on the inclusion of health equity in clinical workflows, et cetera?
Whew, that is the $1 million question. So that is honestly where my research / clinical interest lies for like my whole career, right? I want to take what is happening right now with like Community Care North Carolina and make sure that it's not just helping everybody, but that it's not just promoting equality, but it's also promoting equity and giving extra resources and extra intention to people who are traditionally and continually marginalized from our healthcare system, right? It's not enough to do the same thing for everybody. And I think what research shows over and over again, it's just people don't like to read the research because it's inconvenient, is that when we invest financially, with time, with facilities, with other resources, when we invest in the most marginalized people in our healthcare system, the most chronically ill, the most socioeconomically vulnerable, we actually save vastly more money than when we try to take care of people who are already well embedded into the healthcare system. So I think we have so much data that shows us that equity is the approach we need to be taking, not just equality. And I do think that perhaps, and I don't want to get too controversial, but perhaps some of the vast deficiencies in our healthcare system that COVID is exposing right now will hopefully not just be swept under the rug when this pandemic, is no longer as acute as it is. Because this is showing us that what we need is an equity-based approach, not just a one-size-fits-all. Let's take care of everyone and assume that a rising tide will lift every boat. God, what a good question. Let's all chat after this. Whoa.
Well, thank you so much, Ben, for sharing your work with all of us.
Thank you.
All right, so we are going to move on to our third and final speaker, Mungu Koyog Ochir, and her talk, We Want Clean Air, Mongolia's Air Pollution Crisis. Mungu is a second-year MPH student in the Maternal and Child Health Department. Hailing from Ulaanbaatar, Mongolia, she is also a pediatrician and mother of 3 children. Residents of her hometown, the world's coldest and most polluted capital city, have one dream: clean air. Mungu brings together her clinical expertise and passion for public health and children in her Gillings X talk.
Okay. Hi, everyone. I'm going to share my screen. Thank you for the great introduction, Kate. Hope you all see my screen.
Yes, we're able to see it and hear you.
Okay, thank you. So, hi, everyone. My name is Mungu. I'm a second-year Master of Public Health student in the Department of Maternal and Child Health. I'm also MRTTI lactation student in the Carolina Global Breastfeeding Institute. So today I'm going to talk about the Mongolia's air pollution crisis. So before I start, I want to say hi to my Mongolian friends who joined from Mongolia and other parts of the other places of the US. Okay, let's start. So why I choose this topic to share with the Gillings community, because, okay, because this is very important topic. This is very emerging issue for every Mongolians. No one stand behind the air pollution because it's air. This is my family. I have 3 kids. When we moved in Chapel Hill in 2018, my kids were 6, 4, and 18 months old. So one of the reasons I was really excited about my master program in the Gillings is my kids can breathe the clean air at least these 2 years during my master program. So let's start with a brief information about my country. Okay, Mongolia is the country in Central East Asia. It's between Russia and China. And Mongolia is a 1.5 million square kilometer territories. It's the 18th largest country in the world. It's the 2nd largest landlocked country. The population is only 3 million. And Mongolia is also most sparsely populated country. So what is Mongolia best known for? It's the land of the eternal blue sky. So you can see these beautiful landscapes and eternal blue skies in 260 days a year. We have beautiful 4 seasons, and the climate of the country is extreme continental. We have temperature inversion in summer and winter months, and summer is very warm and very short, and winter is very cold, long, and dry. And the winter average temperature is minus 30 in Celsius, and some places of the country is minus 30 in Celsius. So what makes Mongolia's air polluted? Mongolia, we didn't always face the air pollution. So what happened, this air pollution is the last 3 decades. So in 1990, and we adopted a market-based economy, and the government lifted the restriction on internal migration. So also at that time, we faced very frequent zud. So zud is the Mongolian word for the very severe winter that caused large numbers of livestock die. So all these factors to make the nomadic herder lifestyle less sustainable. So people need the job, people need the money. So they move from rural areas to the Ulaanbaatar. So as a result of this unplanned massive migration, now in Ulaanbaatar, which is the capital city of my country, we have only 2 seasons. So Ulaanbaatar is the most coldest capital city in the world. It's colder than Anchorage, is colder than Antarctica. So now we have only 2 seasons, smoke season and non-smoke season. So non-smoke season is April to September. It's a summer times. It's very nice outside. You can see the eternal blue skies. You can enjoy a lot of outdoor activities. You can see each other. We can see each other. The smoke season is October to March. There is a very thick, dark gray smoke in whole the city. It fills the air of the Ulaanbaatar. So you can see it, you can smell it, even you can taste it. Especially in the northern districts of the country, northern districts of the city, its air quality is very bad. So in Ulaanbaatar, we all breathe toxic air. No one stands behind it. It's a violation of the human rights. The clean air is the basic human right. The city, the Ulaanbaatar, it's designated for only the 500,000 people, but now it's tripled its size since 1990. Now 1.5 million Mongolians live in this overpopulated, overpolluted city. The 60% of Ulaanbaatar residents live in the Gir district, as you can see in this picture behind. So 36% of the Ulaanbaatar population are the children under the age of 14. So how is air quality index in the winter times in Ulaanbaatar? The World Health Organization's air quality guidelines for PM 2.5 is 25 microgram per cubic meter, and in winter times, it can reach in Ulaanbaatar 130 times higher than the suggested maximum level. Can you imagine you breathe here in the United States 130 times toxic air? Is it acceptable here? So we breathe this air, our kids, all Ulaanbaatar residents breathe this air every winter. So in this graph, you can see the hourly measurement of PM 2.5 in Ulaanbaatar, January 2019. So as you can see, the peak levels are the early morning times and the late evening times. So what we are doing these times, We go into our school, the kids go into our school. We drop off our kids in a kindergarten. We go to our work. So every time we go outside during the smoke season, we expose the highest toxic air, PM2.5 toxic airs. So in my country today, the air pollution is #1 public health problem. So more than 4,000 people die. The diseases attributable to the air pollution every year. The fatal deaths are increased in wintertime 3.5 times. The respiratory diseases increased almost 3 times in the last 10 years. The 10% of the all deaths in Ulaanbaatar and the 30% of all cardiopulmonary deaths attributable to the air pollution. Air pollution is very expensive. We spend $85 million a year to all the public health costs, to all the hospitalization costs due to air pollution. So what are the main resources of the air pollution in Ulaanbaatar? 80% of Ulaanbaatar's air pollution is come from the burning rough coal in the Ger district. As I mentioned before, 60% of Mongolians live in the Ger districts in Ulaanbaatar. In these pictures, you can see the Ger inside and outside. The Ger is the nomadic traditional yurt, so we've been living in the Ger very long time. In the center of the Ger, there is a stove. The people burn whatever they can find in winter time to survive in the freezing temperatures. So what are the most plentiful, easy to find, and cheaper source in Mongolia is the rough coal. So who are the most exposed? Who are the most vulnerable to the air pollution? That's the kids, my friends' kids, and my patients. Especially the children under 5 are most vulnerable to the air pollution because their body is still growing, their immune system are still developing, they're breathing 2 times quicker than the adults. They spend more times outside. They're smaller, so they're more closer to the ground. So they go into the school that the peakest high level of PM2.5. So all those factors make them vulnerable to the air pollution. In these 2 pictures, you can see the PM2.5 measurements inside the kindergarten building. It looks 300 micrograms per cubic meter. It's outside in the playground, 999. And you can do some math on that. The normal suggested level, the maximum suggested level of WHO is 25. So what happened our kids' health today because of air pollution in Ulaanbaatar? The children who live in Ulaanbaatar, they have a 40 times lower lung function than children who live in the rural areas. So the pneumonia is the now 2nd most common cause of children under 5. So what I'm really concerning about is what happened tomorrow. We don't know exactly. I'm not talking about here the asthma and respiratory infections. It's a more serious health problems. So it's gonna be cancers, lung cancers, ischemic heart diseases, strokes, and brain development disorders. So this is the picture of how Children's Hospital and Children's Clinics looks like in the winter times in Ulaanbaatar. So as you can see, this picture, very small room, 8 patients. We admitted 8 patients. It's very common. If you don't have enough bed, if you're overloaded, the hospital is overloaded, we admit our patients in the hallways. So the pediatricians work in the winter times 80 hours a week. So we see 50 to 100 patients a day. So it's really devastating for me to see how my own kids and how my friends' kids, how my patients are suffering because air pollution in winter times. So Mongolian parents protested over the air pollution in outside the government building. So they called the government to take action the air pollution. So Mongolian family is trying to protect the kids from the exposure of the air pollution. This is the picture of the public kindergarten in Ulaanbaatar nap time. As you can see in the right corner, the air purifier installed. So we're trying to keep our kids inside and trying to reduce their exposure to the air pollution. So also the families have to make a choice between the clean air or the job opportunities, because outside the Ulaanbaatar, there are very limited economic opportunities. You can't find a job there. You can't find a you can find a job there. So the families are forced to make a choice between them. Also, it's really sad families are separated because of air pollution. They send their kids to the countryside to their grandparents and other relatives that we face today. So what the Mongolian government did for our people to protect from the exposure of air pollution, to tackle the air pollution, they spent $55 million. Until 2015, they distributed the low emission stoves in the Ger districts in suburbs of the Ulaanbaatar, but we didn't see any improvements on that. So most significant step the government did is just a year ago, they started to ban the raw coal in the Ulaanbaatar on May 2019, and they subsidized the electricity costs in the poor households in the Ger districts. I'm very hopeful, and all Mongolians are very hopeful for that, because my friends and the family who live in Ulaanbaatar, they said, we feel much better. The air is much better this year compared to the last years. So also they worked with other donor organizations in a Ger development project and Ger design and innovation projects. So what the experts say is the only possible long-term solution is we need to move from the raw coal to the clean energy. But all these interventions, all the steps that take some time, we can't just reduce air pollution 1 year, 2 years. So what we can do until that time? So we need to reduce the impact of air pollution for our children, for our parents, grandparents, and pregnant women. We need to wear face masks during the smoke season every time we go outside. It's not just surgical face mask. We need to wear the certified N95, P95 masks so that the masks filter the PM 2.5. So we encourage the parents to keep their children inside during the smoke season. So also we trying to improve the indoor air quality to put the air purifiers in the public kindergartens, schools, in the hospitals, and put the air filter in the homes. So also most important thing is we need to improve the public awareness of the air pollution. Air pollution is not a normal thing. So there are a lot of serious health consequences. There are a lot of health consequences, and we need to teach and guide our citizens how to use these air purifiers, how to install their air filters. So this is the reference list I used on my presentation. So if you have any questions, please feel free to email me. I'm happy to answer your questions. So if I don't know the answer, I will connect you with the right person. Thank you so much.
Wonderful. Thank you so much, Mungu, for educating all of us on an issue that is very important to you about your home country. So we have some questions coming in right now. The first one is, how is COVID-19 affecting Mongolia?
So the COVID-19, yesterday we have 16 cases of COVID-19, and 2 of them are the citizens of another country. So Mongolia has a very good, strong system of public health system. We started action early January because we are the border country of the China, the first case reported. So we did action on early January. So we are doing well, I think. I'm really proud of my government, how they do against the COVID-19.
Great, thank you. And another question that we have is, do you think, given the social implications, that it's feasible and sustainable to require the public to wear masks and refrain from letting their children play outside during certain months or times of day when air pollution might be higher?
Can you repeat the question?
Sure. So do you think that a feasible or sustainable solution to this problem would be to require the public in Mongolia to wear masks or prevent their children from playing outside during certain months or times of day when air quality might be harsher than normal?
Yeah, so that's a good question. So we're still working on that. So that masks, I just mentioned that the certified mask is very expensive. Even in the US, it's one each is $10 to $8. So we need to do some projects on that. So subsidize the mask cost or something like. So if we subsidize some cost, the public can accept it. So also we talk in the government still discussing about to change the school years from the winter months to the summer months. I think that's a good, that's a good idea to reduce our kids' exposure to the outdoor air pollution.
Great. So we have time for about one more question. And it's, I have heard proposals that industrialized countries that went through high coal use in the past, but now have widely used cheap electrical heat, have an imperative to help other countries catch up in their use of cleaner energy. Are there any countries helping the Mongolian government pay for these development projects? I know this is a bit of a larger question, so we might need to give you some time to think about that, but if you have any thoughts on that.
Yeah, so what I know about is the Asian Development Banks and the UNICEF and WHOs, they all the international organizations helping the Mongolia to all the projects in anti-air pollution, projects. That's what I know,
Wonderful. Thank you so much for sharing this with us. Let me just share my screen very quickly. All right, so thank you again to our fantastic presenters for sharing their really important work with us. This concludes Gillings X 2020. Our speakers have shared their work, their passions, and most of all, they've been extremely patient with us while trying to navigate all of the different challenges that we have had throughout this entire time with COVID-19. So I really want to thank them for being patient and adapting their talks for us. If you are interested in learning more about Student Global Health Committee or learning more about the events that we are holding, please feel free to follow us on social media. Our handles are below. Thank you all for taking the time to join us and listen to our speakers. We hope that you are staying safe, and we will see you next year for Gillings X 2021.